All right, welcome. In this explainer, we are going to walk through a really practical way to counsel patients on diarrhea. We'll take that simple question at the counter and turn it into a structured professional consultation, making sure you're providing the safest and most effective care possible.
Okay, so here's our game plan for today. We're going to start with that initial patient encounter, figuring out what they're actually saying. Then we'll hit the most important fork in the road. Is it acute or chronic? After that, we'll dive into counseling for the most common cases, learn how to spot a serious red flag, cover advice for special populations, and then wrap it all up with a handy checklist. So picture this. A patient comes up to your counter and asks for something for diarrhea. Right there, our first job is to shift from just grabbing a product to thinking like a clinician. What are they really trying to tell us? Yeah, before we can even think about recommending something, we have to be 100% sure what we're actually treating. This means translating their everyday language into a clear clinical picture. To do that, we can anchor our assessment in the official Rome 4 criteria. This gives us a solid, objective standard. We're officially talking about diarrhea when you have loose or watery stools, that's types 5 to 7 on the Bristol scale, by the way, and it's happening in more than a quarter of their bowel movements. But of course, patients don't walk up and quote the Rome IV criteria, right? They use phrases just like these. So when you hear things like, I have to rush to the bathroom, or that things have changed consistency, or even about oily stools, which might hint at steatorrhea, those are your clinical clues. Those are the phrases that should get your pharmacist brain working.
Okay, so once we're pretty sure we're dealing with diarrhea, we hit this huge fork in the road. And the very next question you ask is, without a doubt, the most important one of the whole consultation. Because how they answer this one question about duration, well, that's going to dictate everything that comes next.
And this slide really lays out that critical difference. Are we talking about something acute, less than 2 weeks? That's probably a self-limiting bug or a medication side effect. Or is it chronic, lasting over a month, which points to something more complex like IBD or IBS that absolutely needs a referral? Making this distinction is it's everything. Let's be real, the vast majority of cases you're going to see at the pharmacy counter are going to be acute. So let's really focus our attention there and build out a super clear, effective counseling plan for these patients. Now, before you even reach for a box on the shelf, your counseling should always start right here. First, review their history, any new medications, any big diet changes. Second, you've got to stress rehydration, but with a proper oral rehydration solution. Make sure you tell them that sugary sports drinks can actually make things worse. And third, recommend a bland diet, the brat diet, once things start to calm down.
Okay, when it comes to over-the-counter products, our two main players here require some really careful counseling. For loperamide, you have to talk about the serious cardiac risks if it's abused at high doses, and you've got to stress that it should be avoided if you think an infection is the cause. Then, with bismuth subsalicylate, you absolutely must prepare the patient for that harmless but kind of startling side effect of a black tongue and black stools. And, of course, screen for any other salicylate use.
Okay, this part is our safety net. We always have to be on the lookout for more serious conditions that need an immediate referral. And the most common one you've got to have on your radar is Clostridio difficile, or C. diff. These right here, these are your red flags. If a patient mentions any of these, but especially that combination of recent antibiotic use or a hospital stay, your internal C. diff alarm bell should be ringing loud and clear. This is not something you manage over the counter. This is a stop and refer them now situation. And here is exactly why catching it is so critical. A staggering 25% of patients who get a C. diff infection will relapse, 1 in 4. That really highlights why a proper, immediate referral and management is just so essential to break that cycle. Okay, if you remember one single thing from this whole section, please make it this. Never recommend an anti-motility agent like loperamide if you have any suspicion of C. diff. If you slow down the gut, you're essentially trapping those toxins inside, and that can lead to a much worse outcome. All right, let's switch gears for a second and talk about two special groups where we have to be even more careful with our recommendations: patients who are pregnant or breastfeeding. For any patient who's pregnant, your go-to first choice recommendation should be a bulk forming agent like psyllium. It's simple. It just works by absorbing water to make the stool firmer. And it's considered first line because it has an excellent safety profile. And just as important as knowing what to recommend is knowing what to avoid. And bismuth subsalicylate is a definite no-go during pregnancy. That salicylate part can be absorbed into the system and poses real risks to the fetus. It's just not worth it. So we have walked through that whole consultation from start to finish. Let's try to boil all of this information down to the one single question that should really anchor your entire approach every single time. The answer, of course, is how long has this been going on? That one simple question completely transforms a basic product request into a professional consultation. It's the key that unlocks safer, more effective care every single time. So think about it. The next time a patient comes to your counter, what other simple questions can you ask to take your practice from just transactional to truly transformational?